The eye is the perfect organ to do genetic research. And I'm quite convinced we're actually going to be hearing more and more the term genetics at ophthalmology conferences.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Mona Dagher and myself, Dr. Hadi Sahed.
Bienvenue à EyeCan, un balado sur l'ophtalmologie sous un angle typiquement canadien avec le Dr. Hadi Sahed et moi-même, Dr. Mona Dagher.
Season 4 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support. Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan.
We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Hey there, eye care enthusiasts. It's Mona and
Hadi, back at it again with EyeCan.
You know it, Hadi. Today's episode is going to be a real eye-opener. Pun intended.
Mona, always with the puns. I promise, folks, today's discussion will be just as sharp as Mona's great wit.
Hey, we're here to keep it both informative and entertaining, right?
Absolutely. So whether you're a seasoned ophthalmologist or just as fascinated by eyes as we are, you're in for a treat.
Hello, everyone, and welcome to another insightful episode of EyeCan. Today, we have a distinguished guest with us, Dr. Sarah Chorfi, and we will delve into the fascinating world of genetic testing. Dr. Chorfi was born and raised in the vibrant city of Montreal, graduating from McGill University's medical school with honors in 2016. Dr. Chorfi continued to excel and completed her ophthalmology residency at the University of Montreal in 2021. To deepen her expertise, she undertook a fellowship in inherited retinal degenerations at the prestigious Mass Eye and Ear Infirmary at Harvard Medical School, and then completed a program in computational genomics at the University of California, Los Angeles.
Dr. Chorfi received a number of awards during her training, including the Initiation to Vision Student Research Award, the McGill Faculty of Medicine Research Bursary, the Lieutenant Governor's Youth Medal, and also a bursary in bio-informatics and computational genomics in ocular genetics at the Department of Ophthalmology at the University of Montreal. She now has a faculty position at the CHUM, Centre Hospitalier de Université de Montréal, where she holds weekly ophthalmic genetics clinics. This is going to be a really exciting chat. Welcome to the EyeCan podcast, Sarah.
Thank you for the very kind introduction, and thank you for having me.
Sarah, let's start with a personal touch. How did you become interested in genetic testing as it applies to ophthalmology?
Okay, that's a tough question because I could say a lot of things about that. But to be brief, I would say my interest started in med school, in pre-med actually. We had a genetic course and I really loved that course. But it was clear to me that I was looking for not genetics as a specialty, but something that could have a bit of surgery. And then it kind of stayed in the back of my mind for several years until I watched, I attended an award lecture at Arvo where Dr. Jean Bennett actually told us the story behind Luxturna, the gene therapy for RP65. And for some reason on that day, it really became obvious that I was going to do a genetics fellowship. And then throughout my fellowship, my interest just grew exponentially.
That's quite a journey. Now, for our listeners who might be new to the topic, can you explain what genetic testing for eyes entails?
Very simply put, when we do genetic testing, we are looking for a mutation that can give us an explanation for a condition. So if we do genetic testing for eyes, then we're looking for the reason why someone may have an ocular condition, basically.
And what is the role of genetics for ophthalmology?
Traditionally, I think some people used to think that genetics or even genetic testing was kind of a luxury or an unnecessary cost for our healthcare system because we couldn't do anything with the information. But in ophthalmology, we kind of have a very big privilege because the eye is the perfect organ to do genetic research. And I'm quite convinced we're actually going to be hearing more and more the term genetics at ophthalmology conferences in the different subspecialties. And that's, I think it's going to happen for several reasons. So first, the eye itself is a very accessible organ. So we can not only inject or give treatments in several ways, but also we can actually see the different structures and visualize the different structures, which is really not available to everybody. Like, for example, if we compare the eye to the liver, you can image the liver, but you cannot see directly the liver. And also, we have a lot of ways to assess for functioning of the eye. So you can do blood tests or things to assess for functioning of the liver, but with the eye, there's many, many different ways to really see what's going on, what impact does a condition have on the eye, but also is a treatment working, yes or no. And I'm going to say also the eye is very special because we have a lot of Mendelian or monogenic conditions. So where only one gene is responsible for the disease. So it allowed us to evolve very quickly in terms of genetic knowledge because it's much easier to find a specific gene when there's only one gene that explains a condition, because then you can track family members and actually identify the gene. And just to give you an idea, when we do a retinal dystrophy panel, we look at 350 genes. That's huge. So I think for all those reasons, I think genetics is very relevant to the eye.
Sarah, that's so insightful. And I suspect for average listener, average ophthalmologist out there, they're probably still not sure what kind of testing is available and what should they order. So can you tell us a little bit more about what types of genetic testing are currently available and what can be detected with those genetic tests?
I like to tell my patients that DNA is like a humongous PDF. And then there's different ways at looking and like searching through the PDF. So the first thing that you can do is single variant testing, where you're looking for a specific mutation in that humongous PDF. So very simply put, you just search for that variant and you see if it's there, yes or no. That's the first type of genetic testing you can do. Then there's single gene testing, where rather than looking for a variant, you're looking for a chapter, because we could think that in that PDF, we have different chapters for different genes. So then in single gene testing, you first extract that chapter from the PDF, and then you have a list of variants that you look for, that you search for in the chapter. And again, the question is, am I going to find that variant in the chapter? After, there is panels, and I would say now the gold standard for genetic testing, at least in ophthalmology, is using panels where we have different panels for different conditions. Like, for example, a retinal dystrophy panel, a corneal dystrophy panel, albinism panel, where each panel has a list of genes. So you are extracting a list of chapters that are relevant to your condition, and then you're looking for known variants in the chapter. So that's, as I said, that's the gold standard now. Let's say there's no explanation, then you kind of can push that further and do either whole exome or whole genome sequencing, where rather than looking for something specific in your PDF, you actually use software to compare your patient's PDF to other people, like normal patients' PDFs, and see if you can find differences or things that could perhaps lead to disease. So that's kind of the second step when you cannot find anything with panel gene testing.
Given that so many of us have been practicing without doing any genetic testing for some time, how would you tell your colleagues what the justification is to do genetic testing? So why, like, what are your reasons to do genetic testings, and how would you guide all of us on deciding when and why to do genetic testing?
I often discuss that with my patients, actually, because they kind of need to decide if they want to go ahead with the testing or not. I give them three main reasons. So the first reason is that when you have a genetic explanation for a condition, it gives you a deeper understanding of your patient, but also allows you to actually PubMed the patient, that gene, and see which treatments were tried, what was the prognosis on other patients. Like it gives you more information, and also allows you to perhaps yourself understand things about the condition in the future, because if you end up with 10 patients with that gene, then you can yourself maybe realize that things are shared with those patients. So to summarize that answer, a better understanding of your patient. Reason number two is that it provides information to the family. And that's not something we talk about a lot here in Canada, at least in Quebec. But where I did my fellowship in the States, people actually had the option to do in vitro fertilization, where they could screen for healthier embryos that didn't have a mutation. So, like, even though it's not something that's really common here, I think we at least owe that to our patient. At least they should have the information, and then they decide what they do with it. But also some patients actually want to know if other family members might be at risk, yes or no. So that's another reason. And then I think the most important reason is more for potential future treatment. And again, like, it used to be thought that there's no need to do genetic testing if we don't have any treatment available. But when Luxturna became available, some patients in some areas of the world were much more fortunate than others, because genetic testing had been done it had started decades prior. So when the treatment became available, it was very easy to identify those patients who were eligible. But then if we don't do that effort before treatment become available, it takes a lot of time then to track down the patient and do the testing. So we're wasting a lot of time, and some patients might be missing out in the future.
Very insightful. Sarah, could you share some clinical examples where genetic testing has proven to be particularly useful?
I have several in mind, but perhaps let me give you one example. So a patient of mine who came in, she had been diagnosed with AMD for years, had kind of those periodic follow-ups, but also had been seen by several specialists for different systemic manifestation, and no one really seemed to understand what she had until she came to our clinic. And the pattern of her quote unquote AMD, in my mind, didn't fit with AMD. It was more suggestive of a mitochondrial condition. So we did genetic testing. We ended up finding that the atrophy in her retina was due to a mitochondrial mutation. And then everything started to make sense, because mitochondrial eye presentations are also linked to other systemic presentation. So then she was referred to the genetic mitochondrial clinic, and from then, like, everything started to make sense. So that's one example of an interesting clinical case.
It's impressive to see how genetic testing can not only diagnose, but also inform proactive measures. That's really enlightening. And when should genetic testing be considered then?
In my opinion, maybe some people may disagree with me, but I feel like we should consider genetic testing in cases where our testing is actually solid, where we have a good chance of finding something that we really believe in. So let me make that more clear. I'll give you an example. For retinal dystrophies, we know that if we order a retinal dystrophy panel, in about 2/3 of cases, we will find an explanation for the condition. And that's an evidence-based explanation. It's not something that, that we're not sure. It's really something that we believe in. So in cases like that, I do recommend doing genetic testing. But then in other cases, like, for example, AMD, where AMD is a polygenic condition, there's still a lot to learn about the genetic causes of AMD. That when we do testing, our conclusions are not very robust. We're not so sure of what we're telling patients. I think in cases like that, perhaps we may wait before it becomes readily available. And that's for sure. That's in a clinical setting. In a research setting, then any genetic testing can be done. But in a clinical setting, I would leave it for conditions where we know we have a better understanding.
Just dovetailing on that, Sarah, in 2024, who do you feel should be ordering these genetic tests? Is it general ophthalmologist? Is it a retina specialist? Should it be a ophthalmic genetics specialist like you? Who's in the best position to order these tests with the knowledge we have right now?
I had to think a lot about that during my fellowship because in the States, many people are ordering genetic testing, including optometrists. And I've seen several cases that actually convinced me that we should be careful about who's ordering genetic testing because sometimes it can backfire. So in my opinion, anyone who has the confidence that they can analyze and interpret the results are entitled to order the genetic testing. But if someone doesn't have the training to actually do a genotype-phenotype correlation, meaning being able to look at the result and being able to say if the result actually fits with the clinical presentation, but also having the resources to refer patients for further care if need be. Like, for example, for the mitochondrial example I gave you, you need to have a structure in your institution so that you can easily refer the patient to a mitochondrial clinic if you find something that's not only eye related. So I think there's two things. You need to have the training, but also need to have kind of the structure around you.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes.
My name is Shahir Rubeka, and I love listening to the EyeCan podcast.
Sarah, you said something I'd love to unpack, which is that in some cases, doing the genetic testing backfired. And so can you share why it would have backfired? I'd love to hear more about those cases.
Let me give you a few examples. So for example, let's say the patient ends up having a gene that is known to cause a syndromic degenerative neurological condition. And you find that, and you don't know that in super rare cases, that gene can also give non-syndromic retinal only presentations. You thus tell the patient that they have that super bad syndrome. They became extremely anxious. And then you refer them to the genetic specialist who only sees them in 7 months. It's been 7 months that they've been kind of anxious about the fact that they're going to have a neurological condition. And then 7 months later, they're being told that, no, in your case, it's probably only going to be the retina. That's a case where I feel like that really backfired. It kind of led to a lot of unnecessary anxiety. Another example where you see a few genes that are uncertain, like, because sometimes, and we can talk about that further, but it's not always obvious that a gene causes disease. So you tell a patient that we have an explanation, and then they go see someone else a few months later, and it turns out it was really not the explanation because the interpretation wasn't made properly. A case where someone is being told that their child has no risk of getting the condition, but then their child ends up having the condition. That's only because that gene rarely can give you autosomal dominant retinal dystrophy, but in most cases it's autosomal recessive. So someone who doesn't really know that ended up telling the patient that since the dad was not carrying the mutation, their child was safe, which again didn't end up being the case.
Those are interesting cases. Sarah, something I'm so curious to hear about, and I'm a little bit hesitant to ask you because to ask you what a typical ophthalmic genetics clinic is like is probably crazy because I suspect that your clinics are full of the wild and wonderful cases. But is there such thing as a tip? Like, what is, if you were to think of the most common reasons for patients to come and see you in your ophthalmic genetics clinics, what are the typical things you're dealing with in your weekly genetics clinics?
At the moment, I would say most of my patients have retinal dystrophies because since there's a therapy for retinal dystrophy, a lot of patients end up being referred. I also get a lot of referrals from the medical genetics service because sometimes they find the gene and they're not sure if the gene fits with the presentation. So they want me to look at certain things in the eyes to tell them if it's actually a gene that fits. I also get all the weird uveitic, maybe yes, maybe no cases that no one really know what the patients have, and they wonder if it's a dystrophy or weird loss of vision that people are uncertain about. So I get a lot of those as well. And then other stuff, but I would say those are the main things I've been seeing.
And outside of what people are already sending you, are there things out there in the community that you feel you should be seeing more of that is not being sent your way? Is there an awareness gap in the ophthalmology community regarding certain conditions that you feel people should be sending you more of?
I guess AMD. When AMD doesn't really look like AMD, I think sometimes people should maybe refer the patients because I told you about the mitochondrial example, but there's also, I saw a case of a patient who had a neurological condition that's associated with kind of an AMD-like pattern in the macula. So I've seen a few AMD cases that I thought perhaps those patients may have benefited from being referred before. And then also in patients who have had retinal dystrophies for years, there's still in some people still have this thought that there's no need, that why would you do genetic testing? But I think it's pretty important, maybe not for the patient themselves, but for their families, because if we end up with a therapy in the future, I think every family should at least know what's their genetic background, if perhaps it might lead to a therapy in the future. So that too, I think is useful to still do the genetic testing, even though the patient have had a condition for years.
And another question that might be controversial, but I think it's worth asking in a public healthcare system, whether it's in cornea or glaucoma or retina, any of our new technologies are being challenged and we're being asked to, show the evidence with regards to the value of these devices or medications to our population. And so are these kinds of conversations happening in genetics? Is there a way to look at the cost effectiveness of these testing, or do you feel it's still too early to have an answer to those questions?
I guess it's definitely too early to provide a number because we're kind of too early on that journey to really assess what the benefit is going to be. I'm super biased because it's my field and I've seen so many benefits from asking for genetic testing. So my answer is no, it's definitely worth it. And again, Luxturna to me is a perfect example because in Quebec, for example, our population, a big chunk of our population still didn't get genetic testing for retinal dystrophies. So then we have the treatment, but we need to find the patients who are eligible for the treatment. So to me, only that is convincing to ask for genetic testing. But also, do we want our field to grow? And do we want to make further discoveries? And do we want our field to improve? If the answer is yes, then I think it's definitely cost effective because without genetic testing, without testing our population, we're never going to make all those future discoveries that actually require us to know what the genetic background of a patient is. So I guess if we want our field to stay where it is now, then yes, let's not do genetic testing and let's save money on that. But if we want our field to evolve, then definitely I think it's worth spending the money for that.
And can you give us an overview of all the genetic diseases of the eye?
That's also why we're privileged in a way in ophthalmology, because every structure of the eye can have a genetic condition. So, if we start from front to back, there's oculopharyngeal muscular dystrophy for eyelids. Then there's corneal dystrophies, glaucoma, cataracts. There's also aneurysmia and anterior segment dysgenesis, retinal dystrophies, optic nerve atrophy that are genetics. So really every single structure of the eye has a genetic component. And there's a lot more to discover. Like glaucoma is a very good example where we're hearing more and more about genetics and glaucoma, but I'm pretty sure we're going to make some groundbreaking discoveries in the future with genetics and glaucoma.
And according to you, which one is the most studied of all the genetic diseases of the eye?
So for now, it's retina, definitely. But in my opinion, there's a lot of room for studying other conditions and not only the retina, because it's been retina for many years, but now I think it's time to also look at other structures of the eye.
Interesting. Thank you so much, Sarah. And before we wrap up this episode of EyeCan, we'd like to shift gears and know more about you and your interests outside of the realm of ophthalmology. Do you have any podcasts that you listen to, any books you're reading?
So I've been recently listening to a podcast in French. It's called Histoire d'enquête on the Radio-Canada app online. I think it's a really cool podcast if anyone's interested. That's the podcast I've been listening to recently.
And soon to be a new mom.
Yes.
Probably busy preparing, huh? It's very soon, isn't it?
Exactly. So yes, I've been super busy with reading about different strollers and all that stuff. Yeah.
Congratulations in advance.
That's so exciting. Congratulations, Sarah. Your expertise is so unique and so interesting. And it sounds like it's such a big part of present ophthalmology and certainly the future of ophthalmology. So thanks for taking the time to share your expertise with us. I've certainly learned a lot, and I'm sure our listeners will as well. So thanks again for spending the time with us today.
Thank you for having me.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes. Season 4 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan. Thank you from the Canadian Ophthalmological Society.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan is available on Apple, Spotify, and Google platforms, and of course, through the COS Practice Resource Center.
Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more.
Thank you for joining us this week. We look forward to bringing you more episodes.